rectal mucosa here. And it's easy to remember that cancer is peripheral because when you do a rectal exam, you feel those malignancies. And so what we're seeing here is the peripheral zone right there. And then we really don't differentiate the central gland or the inner gland. It's just this sort of heterogeneous area. Now, if somebody has a lesion, like homocoa, that's how we'll recognize it. It may be vascular on the sentinel scan as well. So that's really what we're for. And we really only pick them up in the peripheral area of the prostate, as we see here. What happens if we see such a thing? We're going to do a biopsy. We do that transrectally. The indications for biopsy are you feel a mass, you see a mass, or there's an elevated PSA. Most people would use 4 as a cutoff, certainly a lot of PSA. Some people do prostate densities, which I'm not going to go into today. The important thing you want to know is that we just don't biopsy the mass. We biopsy in our lab, and the way you can approach this, you can say, well, the way we do it is we cover the patient with antibiotics, and then we biopsy 6 areas, 3 on each side in the peripheral part of the gland, and we include, of course, the area in question as well. So some people do many more biopsies than that, but the point is you don't just biopsy the area you see. And if you don't see anything in the PSA, you still do those biopsies. Okay, that's it for prostate. Many indications to do renal ultrasound. It's all in your handout. I'm not going to read all this, so you can see what it says. Now, the question is about the normal case. You know what normal looks like. What about a kidney that looks like this? Is a kidney like this ever normal? Well, if you did a pediatric one, the pyramids are very prominent normally. You heard that said, I believe, 2 days ago. But not in an adult. The pyramids are prominent, as we see here. That's not normal. Or the second thing you want to look at is the echo texture. We tend to compare the echo texture to the adjacent structure, and we're typically looking up here. It's more than the liver. It can be equal, or it should be less than the liver. And when we see increased activity or prominent pyramids in an adult chronic disease, often the pyramids acutely are chronic, with relative acute to chronic disease. And then as the disease progresses, the kidney shrinks, the pyramids become less echogenic. Prominent pyramids, big differential, put that in the basket, if you will, of medical renal disease. Basically, we're looking for, is it a medical problem or is it an obstructive problem? And we're going to look for dilatation. So lots of things with medical renal disease. What if I see a big echogenic kidney, as I see here? Not a lot of corticomedullary differentiation. The medulla part has the fat in it, and here everything blends together. So what would be my first thought out of my mouth? Big echogenic kidneys, anybody? Did I hear it? Okay, yes, I did. Big kidneys, HI nephropathy, AIDS nephropathy, or HIV nephropathy. Don't forget also big kidneys. Most common cause of big kidneys across the board would be somebody with adult diabetes, as well. The difference is people who have severe medical renal disease, like a diabetic, often have relative oliguria. Somebody with HIV, they're peeing up a storm. They really well, and they still have this bad disease. So big echogenic kidneys, and then some other findings. This in the literature suggests the enlarged kidney is only 20%. Personally, that has not been my experience. Now, what about this? There's going to be a lot of eyeball use here in this talk, so use your eyeball. Do you appreciate a finding here? What is it? Now, this is because instead of the somalucent pyramids here, and this blends into the fat, this is easier to see because it's getting more discrete. This you should never miss, okay? And this all falls into the terminology compared to normal, corticomedullary with the fat, and pyramids are not normally well seen. Out here in the periphery, we can see pyramids, medullary hypercalcinosis. I'm going to let you look at the differential. I want you to look at the pictures here. But a lot of hypercalcemic states we can see it, and that's basically what we're looking for. So don't get nervous. Make sure you're careful. If you're not seeing anything, go back look at those pyramids again and see if they're echogenic. They may or may not shadow. There's a whole variation in the spectrum of medullary nephrocalcinosis. The differential, I'm saying all of this looks like medullary nephrocalcinosis, but anything where you can see echogenic stuff, if you will, in the kidneys, it's a big differential. Somebody has a Foley catheter, you might have air rising up in the kidney. So let's look at a few examples. We see a fluid collection here. Notice in this case echogenic shadowing. Does that look like a stone? Well, it's flat. Stone's not really flat. Remember we were talking about milk of calcium in the gallbladder the other day? It looks like sludge with shadowing. It's the same thing in the kidney. Here we see something round with maybe a mild degree of shadowing. When you see round, bright echogenic areas that are sort of in the area where you'd expect stones to be, and that could be variable, of course, calculi. And the peripheral kidney with a little shadowing also might be something calcified, but Andrew and I will talk more about them in a few minutes. That's what that is. And this is an unusual case also, echogenic shadowing coming out from within a pyramid. Rare, unusual, but that was a cluster. Okay, just very briefly, you've had talks, very nice ones, about doctor, and several people touched on renal vascular hypertension. The thing I want to emphasize is, if you ever see, and I hope you can appreciate, perhaps in the handout, not just the gait, but an angle correction. When somebody uses an angle correction on the scan, think velocity. Somebody's determining the velocity here. In this case, we're measuring the upslope here. Notice here, we're higher in our velocity, that's 40, lower in our velocity, that's rounded. So you're not doing an RI here. Whenever you see something, a velocity study, think about velocities. If you're not angle correcting, think about resistive indices, that sort of thing. But here, normal, slow, parvus tardus, vascular hypertension. Even if you don't know the numbers, the concept is what's important. There's obstruction further down. You can't get into that kidney well because the blood can't get in, and so it's slowing down on the systolic upstroke and less of the velocity. Now let's turn to the big topic of obstructive renal disease. I wish our pictures looked as beautiful as Dr. Netter's. And of course you can get stones in a variety of locations, out peripherally and more centrally. When you're looking at a kidney, ideally from a coronal as opposed to an AP approach, so you can show the peripheral calyces, the infundibulae, into the pelvis, and even into the collecting system, as we see here, best on a coronal, not an AP scan. And what we're looking for is with obstruction, things such as hydronephrosis, perhaps perinephric fluid if you electroplex, and also not just to say you're dilated, but can you determine the site of an obstruction? Is this a good image? Lots of multiple cysts. Should I say these are multiple cysts in the kidney? Well, this isn't there. You can't just look at a single picture. If I should do a transverse scan of the same patient, notice that they're connecting with each other. And why is that not a good image? Because it was done in an AP version. If you're AP, you could be hitting just the peripheral, very dilated calyces. And notice the difference between that case and this case, multiple cysts. There's a big difference here. And what is this? Polycystic kidney disease. If you were to do a comparison, notice that these cysts are more or less the same size. They're lined up, as the calyces are, into an anterior and a posterior division. The outside of this kidney is usually smoother, although both kidneys can be enlarged. So you can see the difference here, where these kidneys are more lobulated, the cyst size and distribution are variable. Big difference. So technically, you don't want to scan AP in the kidney. It's also important to realize that you may have fluid in the kidney, but not actually be obstructed. It's true in the biliary, can be dilated, but not obstructed. So let's look at the reasons why people may be dilated, but without frank obstruction. Whenever I'm looking at a kidney, sagittal, transverse, and I see a big fluid collection here, I hope you can appreciate the parenchyma, particularly on the transverse image. If I was to draw a line here, that's transverse, that's extra-renal, outside the kidney. That's the portion here that's predominating. Yes, a little fluid is going into the kidney, but there's not a lot of dilatation of the infundibulae and calyces. And here's another example. On a sagittal scan, the parenchyma, extra-renal. So it's maybe a form of an obstruction, but it's a minimal damage to the kidney, and the parenchyma is well preserved. What about this patient? Does this patient have, we're seeing left and right kidney, bilateral nephrosis? Well, looking at it carefully, and especially if you look, notice that the calyces, if you will, do not communicate with each other. And a clip will help, I think. Hopefully you can look at a clip to see careful scanning that these are really not connecting. You have to connect from central dilatation into the peripheral dilatation in order to have hydronephrosis. And if you're having trouble making up your mind, I guess this could be called perirenal or parapelvic cyst. You could do a contrast study, but if you look carefully, you should be able to suggest that diagnosis without actually having the CT. What about this case? Certainly it looks like there's mild dilatation of the pulse here, perhaps not in the calyces. What I always do when I have a question like this is try to use a little color. Wow, look at that light up. And what this is not dilatation at all. It's just prominent central vessels, particularly in women, often with the veins, but sometimes the arteries can be quite prominent together in the center of the kidney there. And so I always put color on. So a differential list of false positives we see here. Don't forget, reflux can cause dilatation. Obviously, that's not an obstruction either. So I'll let you at your leisure review the different areas. We always, when you're dilated, going to go to the bladder. If it's distended, have that patient void. You might want to scan the patient in an erect post-void position, just like you might do on an IVP or other contrast to see if you can drain. Now, what about this case? This patient came in acutely symptomatic. Does anybody see hydronephrosis here? I don't think so. But what about 3 hours later? Now there's dilatation here. So initially, and this patient was obstructed, but it takes time to dilate. And if somebody has an acute obstruction, you might not be dilated, as in an acute stone. People don't wait at home saying, hold on, I'll wait till I dilate. They couldn't because they're so in such pain. So that would be one thing, an acute obstruction. Here's another very important set of images. This is done in utero. And you can clearly see that there's quite a bit of dilatation of the renal pelvis here. The baby's now born and is upstairs in the hospital, NICU perhaps, and you do a study that's only a few days old. Notice that you don't have a lot of dilatation here. It's much less than it was here. Now look at the same baby, 1 month old. What happened? Why was that not very dilated? Well, because if you look at the false negatives, dehydration, we already mentioned acute obstruction in the first case, but also dehydration. These are by far the two most common causes to miss dilatation. Remember, when babies are born, do they lose some weight? Yes, they do. That's because they're dehydrated. That's because they're not taking in fluids well, and also their glomerular filtration rate is not very good initially. It takes a few weeks to get stable, homeostasis. And so if you can, when you're looking at a newborn, ideally, if the baby is relatively asymptomatic, make sure you don't suggest to the clinician that everything's fine because it doesn't look dilated. Always consider, instead of scanning the baby at 3 or 4 days, if you possibly can wait till maybe a few weeks old, you're going to show a more accurate reflection of the degree of dilatation with possible associated obstruction. Those are the two big ones. Occasionally, fornicele rupture can decompress the system, and the others are really unusual. So bringing our eyes to this case now, any problems? It's subtle. If you look very carefully, and if I told you there are acute symptoms, perhaps the patient had a history of renal problems, there is a little bit of fluid there. That is a fornicele rupture. Remember, think about CT. When you see a patient with fornicele rupture, the fluid does not sit around the kidneys. It dissects into the retroperitoneum. So when you rupture fornix, you're not going to have a lot of fluid around that kidney, and it's hard for us to look at the retroperitoneum. So we often get just a minimal clue. So looking at perinephric fluid, that's a good example. Just a teeny wisp of fluid, maybe a teeny bit of hydro. That is a fornicele rupture associated with an acute obstruction. Are there other reasons why you might get fluid around a kidney? Certainly are. What are some of them? Here is a case where if you look at this kidney, it's a bit flat here. History is important. You don't always get the history, but you might want to think about other causes, and one of the common ones is if somebody had a renal biopsy or trauma, but particularly renal biopsies, very often we'll get a little bit of fluid, perinephric fluid here. With a hematoma, sometimes they occur in various other locations. Remember, we talked about blood can become fluid, that's another one. And sometimes you'll see sort of this, looks like fluid surrounding the whole kidney, sort of an inflammatory situation. Think of pancreatitis, severe pancreatitis. You don't only have inflammation sometimes in the pararenal space, but the perirenal space can get involved in as well. And sometimes I honestly don't have an answer. People with renal failure or people who perhaps are hydropic, have a lot of fluid collections all around their body, maybe nephrotic syndrome, and somebody called that one renal sweat. We don't know exactly why, but somebody's got a lot of fluid on board, if you will. May just get a little perinephric fluid. So there's a good differential for you. Now, what about looking for the site of obstruction? And I'm going to focus mainly on stones. You can see Dr. Netter shows 3 sites. Unfortunately, the middle ground here is something we really don't see well. If you think about the geometry of stones, the big stones will probably get stuck up here, so we should see them. The small stones can pass, and often will get stuck down there. Some do get stuck in the middle, trouble there. So the big ones we should see, chronic obstruction, and it may be hard to look through all the sludge. Remember, with long-standing chronic obstructions, sometimes people are at risk for getting neoplasm, particularly you might get a squamous tumor here, and this was just sludge. You might have blood, of course, looking like this, but there's a stone here. Don't just have your eye look at that very dramatic hydronephrosis that you can see here. You can tell it's long-standing because there's no cortex left, and it's a very dramatic degree, marked dilatation. Okay, so if you look, you should be able to see those stones, but the distal stones are the ones that are smaller and harder to see. So really, if you're going to go through fluid-filled bladder, if you transabdominally, you really need, I think, a fluid-filled bladder to see it. And sagittally, we can see it. Transversely, if it's an acute problem, often there'll be some edema of the trigone. So look carefully to see if you see a little edematous mound there, and there is a stone that we can see. Now, in a woman, you can do a transvaginal scan with a fairly empty bladder, I would suggest. And in a man, some people have advocated doing a transrectal scan to look for distal stones. The important thing is to know where to look for them. And if you look at this diagram, this is how the transvaginal put in. We don't go in as far as to look at the cervix, just a little bit to look where the ureter, first where the ureter, and then go a little to the side. We know where the ureter comes in, but the important thing, and the reason people have trouble is they forget when you look on the monitor, this is the feet and that's the head. That's the feet and that's the head. And therefore, that's posterior here, and that's anterior. So by knowing where to look, you often can see it. I hope now that we put a stone in here on the diagram, can you see it on the scan? Right there. And we only see a little bit of the distal ureter. But if you look carefully and you know where to look, you can find it. Here's a very nice example. This was done by Dr. DeSalvo, one of my colleagues. Oh, wouldn't it have been wonderful if that little stone would have popped out right in front of us? That would have been the clip of the decade, but here it just... Oh, get out, but it didn't. Okay. So keep on scanning. But so you can see clearly where that little stone is. Poor patient. I hope the stone is passed since then. Okay. Now something else that helps you find small stones is seen here. And I can tell you, you might see the stone here because I knew where it was. But two good people missed the stone until they put on color. And color is a wonderful helper, if you will. And I'm not sure why we get this thing called a twinkle artifact. It's some kind of a color reverberation between, I don't know exactly the composition of the stone, but I often will pick up stones in the kidney, in the ureter, in the pancreatic duct. They're all similar. If you turn color on, it's a clue. Now look at this clip. I'm sure you all realize there's a jet there. It's hard to see the stone until you put the color. It's going to give you all the help you need. Sometimes we need a lot of help. We lean on all kinds of things, and whatever it takes, just use it. But color is very helpful here. What about, instead of just using color and so forth, some people get ureteral jets. It's like magic. If there's a jet, you have no stone. If there's no jet, you don't have a problem. That is absolutely not true. Untrue. No, no, no. Okay? So I emphasize that point. A beautiful jet. Isn't that nice? Makes pretty pictures. Another beautiful, beautiful jet. Bill Middleton, part of this group here, showed that when you have an incomplete, let's just say incomplete obstruction, the majority of patients have a jet. As a matter of fact, in my experience, and here's the same patient you're looking at with that beautiful jet, see the stone? And you saw it in the case before with the color. There was a visible jet seen without color. You could just see that flow coming in, and that's, I think, why we're seeing the jets. It's flow coming into, the velocity of urine flowing into the bladder is different than the urine in the bladder. It's the difference that allows us to see these jets. Think of a garden hose. You narrow the spigot of a garden hose, so you have like a partial obstruction. What happens to the jet of water out of the hose? It's very powerful. It increases. If I see a very powerful, almost continuous jet, and the patient rises, I say to myself, that patient has a definite obstruction with the jet. If the patient's feeling good and said 5 minutes ago I felt really awful, but now I feel good, and the patient didn't get morphine in between, then you could suggest it's a post-obstructive diuresis, just following passage of stone and look in the bladder, you might find it. Okay? What about, so jets, you have to put into context, and if it's a partial obstruction, you often will see a jet. Some people suggest we should have help in the way of using resistive indices. And there are two ways to do that, looking at the absolute number or the difference between the two kidneys. I favor this, but I do both. And I'm looking actually at an EC number to remember it's a 0.1 difference between the resistive indices of the two kidneys in a symptomatic patient makes me concerned. So let's look at some examples. Here's a patient. This patient was symptomatic on the right side. This RI is above 7, it's 0.76, and the difference between the two is greater than 1, and was symptomatic. Notice here that there was no hydronephrosis. But this patient was really writhing and had a history of stones. Most people do. And by looking then at the RI, I was convinced there had to be a problem. Filled the bladder up, which was not initially filled, then saw the stone, okay? So even though there's no hydro, remember, an acute obstruction, you don't always see hydro. And also, what do people do when they get acutely obstructed? They're often vomiting, they get dehydrated. So you've got two reasons why acute obstructions may not have hydronephrosis, okay? So in this case, it behaves itself in terms of following both of those RI numbers. What about this case? Here we have a patient who's symptomatic on the left side. The RI here is 0.67 compared to 0.56. Okay? No hydronephrosis on either side. But I look down on the left side, the symptomatic side, and above, there's a stone there where the arrow is. So no hydro, but the difference in this case, it was not the absolute number. It was the difference, the greater than 0.1 on the symptomatic side, that made me look harder. So it's a clue. I use resistive indices as a clue. Now what about this third case? Here, everybody appreciates there's dilatation and yes, you connect with each other on clips. So that's bilateral hydronephrosis with normal resistive indices that are symmetric. Well, does that mean that there's no obstruction? Well, it might be no obstruction. It's reflux, but in this case that wasn't true. I knew this patient had lymphoma and had retroperitoneal adenopathy, but why wasn't the RI up? The RI wasn't up because this is chronic obstruction. Your body will compensate. Pregnant women have increased dilatation all the time, particularly on their right side. They have normal RIs. It's a chronic phenomenon. If a woman is symptomatic, acutely who's pregnant, and her RI is up higher compared to the contralateral side, I'm very worried. And I use RI there a lot in pregnancy because that's a chronic dilatation. RI often is normal. And the last case here, RI of the left, 0.9. But there was acute flank pain on that side. Maybe there's mild hydro right there. Always, always do a comparison with the other side because you've got to control. Now look at this. The other side also, 0.8, 0.9. So I have RIs that are up bilaterally, but the patient was only symptomatic on this side, only had hydro on this side. How do I account for the increased RI? Okay? There's something causing it. But maybe it's not an acute obstruction. What this happens to be was another chronic obstruction in this kidney, but it was associated with medical renal disease. And there's a whole bunch of, all the things that cause chronic, those prominent pyramids, etc., they can also be associated with increased resistive index. So, Doppler, acutely, you may not have a high RI with what's listed in front of you, and just remember medical renal disease and everything under there fits in that category can cause an increased RI without obstruction. So you have to put the resistive index into context with what's going on and what you know about the patient. Now let's talk about focal renal masses. Okay, let's start with this case. A lot of cases. Is there a mass here? Well, what do we typically do when we're thinking, is there a mass? Most people would want to do a CT, and if you see that the area of the mass fills in, as it does here, what's the diagnosis? I think you all suggest it's a column of Bertin, okay? Because it has normal functioning tissue, which column it has. And can you do better with ultrasound than what I just showed you? The answer is yes. That looks like a mass to me. Oh, where is it? I put power Doppler on. Power Doppler is like a perfusion. Boy, when we get microbubbles, we're going to really be sound. It's sort of a cheap microbubble, if you will. It shows the perfusion in this kidney, and so at this point, there is no mass. If there's a mass there, it would be distorted architecture. So that is the way ultrasound can show that that is just a column. Now, you have to pay attention to detail in your technique, because remember we talked about that a couple of days ago. Here is the same case. Now, that still looks like a mass. What's the difference between this scan and this scan? Remember I said, if you're using grayscale, use the highest grayscale possible. If you're using Doppler, what do we say? Go to low grayscale. And a low megahertz and a low scale. And so what we did here was we went from a 5 to a 1.5, 1.75, lowering the megahertz of the Doppler allows me more, it's like blasting the Doppler into the patient with much more energy. And so I could see that perfusion. So you don't want to have a bad technique because you'll come up with bad answers. So column over 10 I think you know about is isoechoic with the cortex and normal vascular architecture. So either UCD, but you might get extra points if you say, you know, in our hospital, sometimes we turn power Doppler on, and it's so dramatic. Well, pull that case down. Next case, please. Okay, don't you love that? What about this? Anybody have a problem with this? Of course not. This fulfills all the criteria of a simple renal cyst. You can apply Bosniak criteria to ultrasound just like you do in CT. If it fulfills the criteria, i.e. anechoic, well-defined, good through transmission, do you worry about it? Absolutely not. Don't get follow-up. We see these all the time. I'm not going to go through each of the Bosniak criteria, but I think you can appreciate there's a mass here, and it's much more complex, and that might be considered a 3. And at this point, you want to get a CT. I draw your attention, it's the same case, although yes, there's thickening here, and I'm sure if you put a number on that, it wouldn't be water density. But complex fluid on ultrasound is often better seen than on CT. So realize you might have a discrepancy, and it also might have to do with your how you are scanning in terms of time, the changes you might see in a mass on CT. What about this? Well, that's very complex there. And that is a presumed malignancy, and you've got to do CT, et cetera. Okay. What about this? This is scary. No echoes in it. Well defined, but it lacked good through transmission. There's no through transmission here. That's pretty sneaky. So we put Doppler on. Whoa, lots of flow there. Solid mass, okay? Homogeneous solid masses, be aware. It could be a hypoechoic renal cell, which this was, and they're typically papillary cancers when they look like this. Lymphoma certainly could look like this also. Quite echo-poor and doesn't often have good through treatment. May have some through transmission, but not as much as you'd expect for a cyst that size, okay? Cystic renal cancers can be a variety of appearances, as you can see here, simple, not simple, but unilocular, multilocular. You might have a necrotic mass. Unusual to have what looks like a simple cyst with just a little mural nodule, but they can occur. But I emphasize again, be aware of those hypoechoic solid masses, papillary tumors, sometimes lymphoma. This is an interesting case, was done by somebody in, I won't say who, but this looked solid, and that was read out as solid, okay, May 3rd. I don't know why nobody followed up on this. I honestly don't know, because it should have been followed up. But I had the opportunity to scan the patient, making sure I was 5 months later, and it looks very different, smaller. Bad things get bigger, good things get smaller or stay the same. So I was a little puzzled here until I looked at real time. So this is like a sludge ball, if you will, and that's what it was here. Anytime you see something solid, the next thing you should do before you say it's a tumor, put color on. Okay, and that should have had flow in it, but that wasn't done, and that was read out as a mass, which, you know, there's something wrong with that. Cyst, very complex, but it's certainly not tacked down, and that was a sludge ball. Lookalikes, multiloculated, multiseptated mass, you can't tell the difference. One is a cystic renal cell, the other is a multiloculated cystic nephroma. That's why anything that looks like this has to come out, because we cannot tell the difference. What about this? Well, you might say it's an Aunt Minnie. Particularly, that's the right kidney. Look at the left kidney, then you go to the liver. That is an Aunt Minnie. That is, obviously, adult polycystic renal disease. And you know all about that in the association with aneurysms and complications. Complications we don't do very well with. Bleeding, it's very hard for us to see the complex nature of these because there's so many cysts, there are a lot of artifacts in some of them. So, is this going to be right kidney, left kidney, same patient? Polycystic kidney, is there a differential? We darn tootin' there is. Tuberosclerosis. This is a weird one. This is very unusual. Renal dialysis. That should be a smaller kidney, but this was the truth, okay? Remember here you also have angiomyolipomas. What about this? Oh, that's our index case. That's polycystic kidney. So there is a differential, and try to see if they're associated with anything that could maybe suggest the diagnosis of tuberosclerosis. Okay, what about this? If I told you that's a newborn, would you believe infantile polycystic kidneys? The reason you don't see the cysts are they're so darn small that we just can't see them. So we see a lot of reflected surfaces, large kidneys. And we've heard about this before with the inverse relationship with hepatic fibrosis. The worse the kidney disease, the better the liver, and vice versa. Okay. You saw this case before, so what is it? If you don't get this right, I'll be very upset. Okay, this is multilocular cystic nephroma. What about this? Different patient. You can see again complexity seen on CT versus ultrasound. All of this, both patients have multilocular cystic nephroma or multilocular cysts. The literature, realized, has a variety of names, so AKA. It tends to occur in fairly young boys and middle-aged women. Typically, the ones that behave themselves in a classic are usually in the middle, maybe in the lower third of the kidney. You may have some calcifications. We're moving on. What about this? Patient 1, patient 2. I think you realize that there's a mass in this kidney for sure. There's architectural distortion in this kidney. The upper pole is big. You have to go through the whole kidney to make sure it wasn't technical, but it was big. Any solid mass that you see in a kidney, first thing you should think about is a neoplasm. And remember, one of the problems with renal neoplasms or renal cells, on ultrasound, the majority of them are isoechoic. So you have to depend upon a focal mass here or architectural distortion. This is a pretty unusual example. What are you going to do when you have this? Are there any clues that will help you? Just like when we were talking about hepatomas going into the veins, well, these also grow into veins. Here's the IVC. We can see that. If you see arterial flow coming out of the IVC, that's no gland thrombus, especially for the mass in the kidney, that's invasion. And you want to look for that. That's how you get all the additional clues that you need to hit a home run and slide home into Fenway Park, of course, with the Red Sox being the team at that, right? You're all going to be Red Sox fans, right? Right? Any Yankees here? Get out of the room. Okay, what about this case? Any problem? Well, it's a dirty image. It's not a pretty image. It doesn't have breakthrough transmission. Always look. People forget about that. Turn Doppler on. Anytime you have any suspicion, turn Doppler on. It will help you out. I can't tell you how useful it is. It's a renal cell. It's a hypoechoic renal cell. Sometimes there's so much architectural distortion. There's a lady who was on hemodialysis and had very distorted end-stage kidney, and we thought as we looked carefully that there might be a mass there. So what did I do? There's poor blood flow in a kidney like this, so power Doppler. If you're having trouble with conventional Doppler, power Doppler. And by doing that, we had struggled, but we could see architectural vascular distortion. We were concerned, and that turned out to be a renal cell. These people are at more risk to get it. So that's a very subtle case, but just to share how tough some of these can be. What about a case that looks like this? Obviously, there's a big whatever sticking off the end of the kidney, the shadow. When you get into a CT, yeah, it shows you the same thing. What will you worry about? Oh, several things, but one of which would be a renal cell carcinoma with calcification. That's a lot of calcification. The calcification that you have the most correlation with malignancy is central calcification, although you're not going to ignore this kind of diffuse calcification. And you see this case? Look at the next one. Looks the same, identical. The scan is done in July of 2000. 2 years later, didn't change. So I doubt that's going to be a renal cell, although it could be. They don't always grow quickly. But in this case, we knew more about the patient just to show you that there is a differential for just about anything. What about this case? Everybody looking? I'm sure you see that mass, right? That's clearly a worrisome mass. But do you have multiple renal cells? You sure can. Don't forget to look elsewhere. Don't forget to correlate with what you have. You may see a second lesion there? Whoa, there it is. Central dense calcification, 2 renal cells. And they don't have to look exactly alike, as in this case. What about this case? Well, there's architectural distortion. And admittedly, I did show you one case of a hypernephroma. I said that's rare. In this case, that's the right kidney, that's the left kidney. It's hard to see a mass here, but I think we would all agree there's something very different between these 2 kidneys. What should I be thinking of? Could be a very unusual hypernephroma, but I wouldn't put that first. Something that infiltrates, which could be, come on, oh, right, you all looking in the book? No, you wouldn't do that. Central mass here, I suppose it could be blood, it could be a sludge ball, I don't know, it could be a lot of things. But when it's central, particularly, this isn't the best case. I'd like to see more hydronephrosis around this, but I would have to think of something like a transitional cell. Put color on, you'll see flow. Okay, that was a transitional cell. Always want to look down in the bladder when you have a transitional cell because they're multicentric. They can be seen in multiple places. So if you see something in the bladder and then in the kidney, think of transitional cell. What about this? This is sort of almost an mini echogenic. Notice that's 4 megahertz, 6 megahertz, 8 megahertz. Going up. What's the difference between 8 and 4? Notice there's an acoustic shadow developing as I go up in frequency. That's because I would have been previously looking for sound attenuation, and sound attenuation occurs with that. And if I see that, then the diagnosis most likely, I won't say 100%, but most likely the first words out of my mouth would be an angiomyolipoma. Do I do a CT? Well, if it's over a centimeter, I probably do, to confirm that it's really fat. I know of one renal cell that I'm not showing you that had shadowing and looked like this. So, when you're trying to think of an echogenic renal cell versus an angiomyolipoma, what differential characteristics can we use? Well, I was emphasizing the acoustic shadowing because of fat, just like on CT. And if it doesn't look just homogeneously echogenic, i.e. there's cystic spaces, peripheral halo, just like in the liver, you worry about it. No halo in the liver, angioma. No halo in the kidney, probably angiomyolipoma. Having IVC involvement is not helpful, and bilateral, multiple, sometimes we said renal cell can be more than one. So is this an angiomyolipoma? Well, it's more heterogeneous than we're used to seeing, and there's no shadowing for that much echogenicity. Okay? So that was not myelopoma. What about this one, right there? Is that angiomyolipoma? Well, there is acoustic shadowing there, right? So it probably has some fat in it. But what's against the diagnosis? The shape. It's not round. Masses that are bad are round. That's sort of concave up there. So it's like a vacuum effect, if you will. Cortical scar. And yes, there's fat coming in there, which is why we saw the shadowing. Okay, last case. Is this an angiomyolipoma? Well, the problem is, for this size, there's no shadowing. There are cystic spaces. There's a halo. And it's not quite as echogenic as I'd like. Scan the patient, and the history helped. This patient was acutely symptomatic with fever, et cetera, et cetera. We scanned the patient a little bit later, and it was changing. This is lobar nephronia, which can appear very variable, but the history is important, and it can be echogenic. It's usually more isoechoic, swollen kidneys, focal pyelonephritis, if you will. So we've talked about the differential for renal masses, pseudotumor, renal cyst, inflammation. And if you think about solid masses, the differential, which we see here, not really hemorrhage cyst, obviously, but it's a cyst, but it's got echoes in it. But the majority, the first, second, and third thing you should be worrying about is neoplasm, okay? All those at the top of the list, neoplasm. Not all malignant, but neoplasm. Moving right along now down into the bladder, I'm not going to talk about all of these things, but just try to highlight a few things. Bladder neoplasm, the big one that you think of is transitional cell multi-epithelial squamous when there's underlying problems with chronic infection, i.e. you may have that with calculus disease, you may have it with a long-standing obstruction, we already said. The rest are rare, children, rhabdomyocyte harmless. So here, multiple polypoid, just like Dr. Netter shows, large, small, bigger, frond-like. Okay, those are both bladder primaries, transitional cells. What about this? Is there a differential? Yes, there is. One thing you always want to do, picture this flow. I don't know if you get flow in this case, but this is a young woman, painful periods. Good place sometimes to see endometriosis. She may be bleeding every month, not just vaginally, but in her urine as well. Okay, so that's it's pretty unusual, but it's certainly I've seen more than 5 cases in my 50 years of no. You didn't think I was really that old, did you? Okay. Yes, some of you might. Never mind, we won't go there. Okay, so here is a plaque-like area abnormality. That's transitional cell too. So you know it's not only the polypoid, it can be plaque-like, but here's something totally different. So yes, there's a differential. This is a patient with cholecystitis and some chemotherapeutic agents. Is it Cytoxan? Am I right about that? Yes? Okay. Any other ones? But some of the chemotherapeutic agents can do that. Anything else? Yes. Don't forget. Blood clot can do it. Pus can do it. Always put color on. See if you get flow. That will tell you for sure it's not something like blood or pus. Okay? What about this? Something here is invading or into the bladder and there's a mass there. It's a woman. Cervical cancer. A man. Prostate cancer. Yes, a median lobe can sometimes do this. You can see that prominent indentation. But this was somebody we knew had prostate cancer and didn't have this mass a year ago. Nothing wrong with saying, I can't tell if that's a median lobe of the prostate coming up, but you know, if I had a comparative study, maybe I could give more information. You're thinking when you talk like that, okay? You can't always tell in a single image. So those are metastatic or direct spread, if you will, cervical and prostate. Certainly do that. What about this? I think this is, here, see that mass coming? That's from a big prostate. That's sort of that coming up into the prostate. And Dr. Netter shows us what this is, a big trabeculated bladder. Obviously, people get those kind of bladders when they can't urinate. Don't forget about a neurogenic bladder. It's not always going to be a mass in the prostate that you're going to see. Sometimes you can see smooth changes, but usually trabeculation is what you're looking for. And if you see smooth changes like this, I would think more in terms of cystitis and, you know, maybe I would put in a bladder outlet problem, but usually they're more trabeculated as in here. So occasionally it can look like that. What about this? It's sort of an Aunt Minnie. It's a sagittal scan. So we're looking at that extension superiorly off the bladder. So that's a bit like this. Remember that these have stasis of urine, and if they're going to get a neoplasm, we've already talked about transitional carcinomas, we've mentioned squamous carcinomas. This, because there's the type of epithelial tissue in here, these are subject to getting mucinous adenocarcinomas, and these are very malignant tumors. So that's the complication here. So now we have different patients. We also have an outpouching, if you will, off the bladder, but this is not coming off the dome. This is an acquired bladder diverticulum, and again, you can see these occur anywhere, but not typically in the dome. I'm not sure why that is, but it's not. And you see that in people who have, notice maybe a little trabeculation here. People who can't squeeze it out, something's got to give, and a diverticulum forms. Often they're simple, narrow neck. With heat, sometimes the blood goes in, the urine goes in there. They get bigger after you urinate. That's quite classic. Notice they can get infected and traps, you know, with chronic stasis, they can get stones in there. And if these people form carcinoma because of the chronic inflammation, that's usually transitional cell. Or, am I right about that? Squamous cell, that's a mistake. Bad, okay. Squamous cell, next year, if you're back here, I hope not. We'll have squamous cell, yeah. If you want to pay them as a board certified radiologist, here's a patient now. Looking at this, that's very flat. It could be a tumor. I'd always put color on, but in this, a nice clip shows you it's just stasis, one dependent. But that's different than this patient with the stone and wall thickening. That I'd worry about. That was cancer with chronic infection. Okay, we still have time, and I'm still talking. Okay. Testicular pathology. We can see lots of different things. We're very good at seeing these things. We are not specific when we see things. The testicle can have focal disease, diffuse disease, isoechoic, anything. But we're good at seeing these things. We need history often to tell us. The real thing is, when you talk about the testicle, you don't want to sit there and scratch your head. I think it's this or think it's that, because you know, we don't biopsy the testis. If you're really worried, orchiectomy is what we usually do. So you really want to be as definitive as possible. And what guidelines do I use? If I see something that's solid in the testis, and it's palpable, and especially if the patient's asymptomatic, history counts, asymptomatic, I'm going to worry. And I'm also going to worry even if I can't feel it, i.e. it's small, real small. If it's a simple cyst, and peripherally, if I can palpate it, and I'll show you what I mean by that in just a minute, I really don't worry about cysts, providing they're simple. And when they're peripheral, they feel like little palpable things. I'll talk about that in a minute. Tumors of the testis are divided into seminomas and non-seminomas, the broad term. Non-seminomas are further subdivided. And you can see from these differentials of the non-seminomas why you would have tumor markers seen here, because you have such things as choriocarcinoma, so don't be surprised that your HCG should be up. You have primitive cells like yolk sacs or embryonal that your alpha-fetoprotein may be up. So these are, and often these are mixed. Most of these have elements of both. Lots of causes. I suppose the first thing I should put down is you have to be a man. That would be good. But what's very interesting, you should laugh at that. That was kind of, all right. This isn't funny though. I didn't realize there was a great radiographics article a few years ago, Caucasian men, and as I think that is true, okay? And lots of other underlying things I'll let you look at. This is sort of the index case of what a seminome looks like. It's fairly homogeneous, as we can see here. Sometimes they have these bands of fibrous tissue. Notice the size of this thing? 2 fields were taken up to show it. Don't tell me he couldn't feel it. You know, it's just amazing how big these can be. Okay. These are less aggressive in comparison to seminomas, and the typical appearance is quite homogeneous, as we showed you. I showed you a case that was globally involved. This is focal, but you can't tell. This is much more heterogeneous, and that is also a seminoma. Does blood flow help me in the testis? Not really. Anything that's large and solid, be it inflammatory, be it a neoplasm, obviously not with an infarct, but it doesn't really, most of those lesions are vascular. Now compare this, again, look at the size of this. Here's the normal size testis over here. Notice microcalcifications, but look how big that thing is. Much more complex. Non-seminomas, more aggressive. Okay. A mixed tumor, can I tell what they are? No. Embryonal? Maybe some calcification, so teratoma. What you really need to do, pathologists tell you, because any of these are going to come out, and you might be getting tumor markers. Why do you get tumor markers? To make the diagnosis? No, the pathologist makes the diagnosis. Tumor markers are going to follow the course of disease. Obviously, it should go to 0 after you've treated the patient. Well, if it starts to rise again, you know you've got a recurrence. So not with seminomas, unusual with seminomas, but these are not that different. They both look fairly homogeneous. Non-seminoma. Tumor markers are up in the majority of patients with non-seminomas. What about this? Bilateral disease. That's pretty unusual, the primary testicular disease, or seminoma, non-seminoma. Think about things like lymphoma or metastatic disease. So this is one form. HIV patients often will get lymphoma and may get it into their scrotum, as in this case. Large, heterogeneous, maybe not so firm as you would think of, with masses, and very vascular. This is a lymphoma leukemia kind of picture. So, and as firm as the kind of tumors that I've been showing you. Okay, often, well, not often, third bilateral. Metastatic disease. We don't usually image the testes in people who have these primaries, but the books say these are the metastatic processes. What about this? You all know what this is, right? Microlithiasis. Do we worry? Well, depends sort of who you read, but I do worry. And we all know about some associated conditions, but the big question is, what about the incidence in terms of getting germ cell tumors? Some people have said there's two forms, classic, this comes out of Mallinckrodt, or limited. Notice just a few microliths. Do I worry? I worry about all of them, I really do. And again, you can say, well, in our institution, the way we approach this is, here you can see a mass, notice both testes have microlithiasis, with many microliths. Here, there's only a few microliths, limited, but both adenomas. What we do is we try to instruct these men to do self-examination, and we, in our hospital, tend to, if we can, to watch them, bring them back every year to look at them with ultrasound. And that may be varied in your practice, so tell it like it is in your practice. What about this? This can rule out a mass, okay? And I think you can see it's hypochondrous. But if you look at this patient, and obviously a clip makes it better, look at this clip. First of all, I couldn't feel anything. That's the first thing you want to know. Does it correlate with the clinical exam? Nothing. So then I came in from the side, and there is no mass there. This is just a prominent mediastinum, if you will, because there's fibrofatty tissue there to attenuate the sound. So let's talk about things, because we talked about things we worry about. Let's talk about things we don't worry about. What about that? Is that a laceration? Well, not really. Put color on when you're concerned. That is a horizontal vessel. Most vessels pierce perpendicular to the capsule, but these are common variations. Obviously, you don't worry about it. It's often bilateral. We talked about cysts before. You can have cysts that are central and cysts that are peripheral, okay? And these are intratesticular. And the little peripheral ones on the edge that are palpable like little BB, cysts of the tunica albuginea. We don't want to make sure it's a simple cyst. There's nothing around that. We don't want it. You may palpate both of those. What about this? I think you know what this is. It's a transverse scan with these sort of bands of little cystic things. But if you go sagittally, it goes in a sagittal plane. Remember, masses tend to be round. This is following the anatomy, if you will, of the mediastinum. So what we have here are cysts in the rete testis, which live in the mediastinum here, right? It's dilatation of these vessels. It's often bilateral, maybe not perfectly symmetric. Why do people get this? They often get it because of an obstruction somewhere out here. So the sperm can't get out, and so you dilate these little tubules. So it shouldn't surprise you that you get cysts in your epididymis as well. And a good history is post-vasectomy. Often we see that. And the the blurb on that, if you will. Okay. What about this? Do you worry about this? A little linear calcification, not to cause shadowing there. Here we can see it well because of the hypercele. It is located on the tunica albuginea, or the covering of the testis. Do we worry about it? No. I don't know exactly why people get that. Maybe I think it's inflammatory, but we do not worry. It's not a mass. What about this? A little bit of fluid here, hydrocele fluid. Now watch these great clips. This is one of my favorites. Popcorn. I guess popcorn at the break, but not this one. Notice it says scrotal pearl. I don't know exactly what causes this, but got to be careful not to laugh when you scan somebody's scrotum, but that was so funny. Even the patient cracked up, you know. Probably due to inflammation of the tunica or infarcted the appendages that you can see associated with the testis or the epididymis. Now, what about this? A little something, maybe a little calcification there. What about this? Sorry, that should say patient 2. That's my error. So 2 different patients. Well, I don't know about that. This patient was asymptomatic, I don't know, because we didn't take it out, the testis. This patient had a germ cell tumor. Anytime I see something like this, I'm going to want to know something about the patient. And if there is any masses, history of anything like a germ cell tumor, and I see something like that, you're obligated to do an orchiectomy. Because I can't tell you that there are few little living tumor cells. But sometimes, for some reason, these infarct or become fibrotic and are no longer tumor. But if you want to get a history there. What about this? Didn't used to see this. But now we can see these striations, if you will. It's normal in this patient is hydrocele. It's probably seen in older people, primarily testicular fibrosis and atrophy. And often if you put color on, you'll see vessels coursing through these zebra-like hypoechoic bands. So the no-touch lesions that we talked about here on the faster, okay, you saw those. They're in your handout. What about this? A different patient, acutely symptomatic. Notice that the tail of the epididymis is large compared, okay, and it's hypoechoic. The patient's acutely symptomatic hurting. That is one of the features that we'll look for with acute epididymitis. It's a retrograde infection, just like PID is in a woman. So if you think retrograde, the tail is going to be involved before it spread into the testis, either via the mediastinum or by contiguous spread, as we see here. Hydroceles are certainly common here. They may be simple or complex. You may see abscesses, so look in the neighborhood of the testis in contiguity with the epididymis. There's an abscess. Doppler doesn't surprise you that often there's an orchitis, and normally you can see a little flow in the epididymis, but that is what a friend of mine called great balls of fire. That's a lot of flow there. Oh, I know, that's pretty bad. So you just got to have some humor in this, you know? I mean, you've been sitting there for 4.5 days already. This is the normal. Always start with the normal, set your machine up, and then go to the opposite side. Okay. Remember, there is a differential for what could be orchitis, including torsion, which is acute, and sometimes tumors present with acute paination. So anytime you see what looks like it could be an abscess or inflammation testis associated with epididymitis, make sure you get a follow-up scan. It's like pneumonia, too. It may take a long time for that testis to get better looking. Okay. What about this? There's a newborn. If you look carefully, there's fluid completely encircling that testis. When I see fluid encircling the testis, bell clapper. In contradistinction to superior, anterior, maybe inferior, but not behind the testis. That's a hydrocele. Okay? I'm sure you know about torsion. That's bilateral. So if you have a torsion on one side, the urologist needs to tack down the other. And it's due to this abnormal investment, if you will, as the testis comes through the inguinal canal, with the ability to have surrounding tunica vaginalis completely around the testis, which was analogous to the image I showed you on that baby. Okay, what happens when you have a bell clapper? Well, you're at risk for these things. Patient 1 is symptomatic on the right. Patient 2, and has skin thickening. Patient 2 is, notice, hypoechoic, hyperechoic. What about patient 3? Well, I don't know. The testes look normal, but that was the symptomatic. A symptomatic person with a testis, but very acutely symptomatic, I'm going to worry about. And I ideally want to see that patient when this still looks normal, because when it looks normal, it's more likely to be viable at surgery. So what you really want to do, you have to use blood flow and Doppler. Set the normal side first, and there's no flow here on this side. Unfortunately, this one was, by the time it looks like this, it's almost always inflated. So acutely, if it looks normal and you put color on and you don't see flow, that's the patient you worry about. Think about going up into the inguinal area to see if you can actually see the torsed that vasculature. And here we can see a nice example. It looks like a hurricane coming in. that twist, if you will, should look like also. What about this? At the edge, history is important, but notice there's disruption here, and that's what the picture looked like. I think people who have anything that you worry about with a disruption probably should go to surgery, because you can form antibodies to sperm as this extravasates, and then you can, if you form antibodies, you may be sterile antibodies on the opposite side. So you may have focal disease, hypoechosis. You may have diffuse disease, more heterogeneous, but notice the shape of this is very abnormal. This was completely disrupted testis in many areas. Notice around it, you have irregular hypoechoic stuff, which is a metastele. What about this with trauma? That's not a vessel, that's a big laceration. We talked a bit about hydroceles already. They may be simple, complex, lots of different etiologies, but it's important to realize that neoplasm is distinctly unusual. You may have one, but they're not predominant. Everything else you think about but neoplasm. What you get is fluid, as Dr. Netter shows so nicely here, but not behind the testis where the epidermis sits. These cases, a whole bunch of cases here. In each of these cases, there's a hydrocele, but we have focal collection in the epididymis. It can be pushing down against the testis. It's a mass. You see it's pushing down here, and they may be multiple. This is what epididymal cysts or spermatoceles can look like, okay? And these are operated on for cosmetic reasons. What happens if you see this? That looks like bowel. This is harder. What else can come into the scrotal sac in addition to bowel? Poorly defined echogenic stuff. If you show you a clip, you got it made, because that would be a hernia, right? So you can see bowel and fat. Fat is tough to see. What about this? Well, that's easy. You stand the patient up, it gets bigger. That's a varicocele, okay? Very briefly, varicoceles. We all know the left side is more common than the right, but do we worry? I divide varicoceles into primary, secondary. Primary are the kind we see all the time on the left side with incompetent valves. And because there's communication of the spermatic vein with the IVC and the renal vein, these will show changes with Valsalva and placing the patient erect. As opposed to if there's a mass, then you do not get those kind of changes with Valsalva or the erect position. They can occur anywhere, around the cord, around the testis. And here's just another one. Do you need a color? Not really. Just turn up your gain setting, you'll probably see it even better. And I just want to end with, well, unusual cases. What about this? What's that? You all know that, and look at this poor man. It even has microlithiasis here. But the question I'm going to ask you is, you see the size of that testis? Look at the size of that prosthesis. Do you think this patient said to the urologist, you know, you're going to take out my testicle, but you're going to put a prosthesis in, just make it a little bigger. I'll feel better. Do you think he said that? No. What it is this is filled with silicone, and sound goes more slowly through silicone than soft tissue. Ultrasound artifact. Okay, what about this one? This is a very unusual case. I did it years ago. Sagittal scan. 1 testis, 2 testes. He had 4 testicles. And I said to him, are more merrier? And he said, well, I'm a 4-star general. I deserve more. Okay. I'm going to end here. Do not panic. Just take it easy. All you have to have your sitting in. Well, I'd like to thank you. That's the end of my talks. And again, thank you all for coming.